Assalamu alaikum. The long clinical consultation day. The first scenario, Mrs. Margaret Gibbs, 45 years old, present to the emergency with abdominal pain. Please take history, examine the patient, and discuss the diagnosis and treatment plan with her.
He start Dr. Bassem.
Yeah, you can start, Dr. Ahmed.
Okay.
Here you go.
Hello, I'm Dr. Naji, one of the doctor in the clinic today. Are you Miss Margaret, 45 years old?
Yes, doctor.
Okay, nice to meet you, Miss Margaret. We are here today to discuss some issue about your health condition, and I want to examine you also. It's okay with you?
Yes, doctor, sure.
Okay, Miss Margaret, you can tell me why you came to the clinic today?
Doctor, actually, I came to the emergency and I've been having pain in my tummy. I'm pointing to the
Yes.
epigastric region. Okay, it's been there for it's there about a few days ago and it's becoming worse. So I thought to come to the emergency because it's really, really painful.
Okay, I'm sorry for that. Miss Margaret, this is first time you have this pain?
No, doctor, and that is why I've come back because the last time I came, I was told that whenever if this pain persists, I should come back. That's why I'm here, doctor.
Okay, you tell me this is not first time. You can tell me first time when exactly?
Okay, the first time was about a month ago. It was the same pain in the same area. So I came in and doctor told me that I have something in I think in my pancreas, if I remember very well. Yes, he told me that, and it says that it might come back, and if I do have similar pain, I should come back to the hospital. And this feels exactly like where I had then, and that's why I'm here.
Okay, Miss Margaret, you can tell me this pain increase from day to day?
It's getting worse in the last since about 3 days ago.
Since 3 days, it's worse. There is any another symptom came with this tummy pain, like nausea or vomiting?
Yes, I vomited twice, and I very nauseated.
Okay, Miss Margaret. This you can tell me what's the nature of this pain? It's dull or throbbing?
It's dull pain. It's like a dull pain, doctor.
Okay. Okay, this pain radiating to any area?
Yeah, it goes to my back.
If I give you score for this pain, you can tell me how much from 1 to 10?
I'll say it hits. It's very painful.
10? Okay.
8. I'll say 8. Very
8.
painful, yes.
Okay. There is any another complaint like loose motion?
No, doctor.
Any hard stool, Miss Margaret?
No.
Any tummy distension?
No.
Okay. I want to ask you, you observe any change in color of your eye
No.
to yellow color?
No. No.
Any change in the urine, in the water work to dark color?
No, doctor.
Okay, Miss Margaret. There is any mouth sore?
No.
Okay. What's about your weight? You have increase or decrease in the weight, Miss Margaret?
No, my weight has not changed, doctor.
Okay, I want to ask you, you complain any problem before in the abdomen?
Apart from the pain I had a month ago, nothing else, doctor.
Oh, no. But you not have any history of the problem in the liver or have a stone or you did anything?
No, doctor.
Okay, Miss Margaret. There is any headache?
No.
Any problem in the vision or double vision?
No.
You lose of conscious?
No.
Okay. You told me you lose of weight. How many kg? Sorry, Miss Margaret.
No, I have not lost weight, doctor.
You're not loss of weight. Okay. There is any lump or bump in your body?
No.
Okay. There is any night sweat or high temperature?
No.
You tolerated for hot or you intolerated for hot or cold weather?
No, I don't have issues with weather.
Okay, there is any chest pain, Miss Margaret?
Any what?
Chest pain,
No chest pain.
shortness of breath?
No,
Okay, any cough?
no cough.
Okay, I want to ask you, there is any leg swelling?
No leg swelling.
Okay, I want to ask you some personal question, if you not
Mm.
mind.
Mhm.
You have regular partner, Miss Margaret?
Do I have what?
Regular partner,
Regular
partner.
blood thinner? No.
No,
Mm.
you are
No,
not
partner,
married.
partner.
Okay,
Any,
partner.
any
Yes, I have a
partner.
regular partner. Yes, I have a regular partner.
Okay, you have children, Miss Margaret?
Yes, doctor, I have kids. I have 2 kids.
Okay, Miss Margaret. Okay, you have any past medical history? I must know about it. Any chronic disease?
Well, doctor, I've been told that I have recently by my GP that I have diabetes, and well, I've been getting treatment for that anyway. It's just about 2 months ago.
You okay? What's the medication you use for this diabetic?
Metformin.
Okay, you can tell me you change the dose or increase the dose?
No.
Okay, Miss Margaret. Another any family history?
Well, I have
Any
family
disease?
history of
Yeah.
family history of what, doctor?
You have any family history of the same problem like you?
No, not I'm aware of.
Another disease in your family?
Well, my father had stroke.
Yes.
Yeah, but yeah, he's been managing well with that for over 30 years now. Yeah.
Okay, Miss Margaret, are you smoking?
Yes, I smoke, doctor.
How many cigarettes per day?
I smoke about 10 a day. I've been smoking for about 10 years.
Oh, I'm so better to stop that, Miss Margaret, for your health. It's okay.
Mm.
If you need, I can refer for you for the clinic to help you. You drink alcohol, Miss Margaret?
Yes, I do, doctor.
You can tell me how many units per week?
Well, I take within allowable range, doctor. Just about.
What?
I take within allowable range, like 8 units a week.
18 per week?
8.
8. Okay, Miss Margaret. You have a regular period?
Yes, I do have regular period.
Okay. Any chance of pregnancy now, Miss Margaret?
No, I'm not.
Okay. You use any oral contraceptives? Any oral contraceptive pills, Miss Margaret?
No, I don't use any pills.
Any history of the loss of fetus or abortion, Miss Margaret?
No, doctor.
Okay, if you allow it for me, I want to examine you, Miss Margaret.
It's all
I
right.
start by your hand. I want to check if there is any clubbing
Mm,
or palmar erythema.
mhm.
Okay. Any debitan contraction in the hand.
No dupital contraction. No
Okay,
erythema.
I want to examine the pulse, regular, volume.
The pulse is regular.
Okay, then I will go to the face. I want to examine. There is, sorry, blood pressure. It's okay.
Blood pressure is normal.
Okay, sitting and standing.
Yes. No posture. No difference.
Okay, in the face, there is any pallor or jaundice.
No jaundice. No pallor.
Any parotid enlargement.
No parotic enlargement.
Okay, you can open the mouth and I will check if there is mouth sore or any.
No mouth sore, doctor.
Okay, I will go for the abdomen. I want to
Mhm.
start by inspection. There is any distension or any scar.
No distension. No scar.
Okay, and they start by superficial palpation, then deep palpation. There is tenderness.
Tenderness in the epigastric region.
Okay, there is any organomegaly,
No.
hepatomegaly or splenomegaly.
No.
Okay, Miss Margaret, I want to do percussion. There is any ascites or shifting dullness?
No, doctor.
Okay, I want to hearing the abdomen for auscultation for the. I will do ballotment for the kidney. There is any enlargement?
No ballotable.
Okay, auscultation for the renal bruit and intestinal sound normal.
Yes, normal.
Okay, lower limb. There is any edema?
No edema, doctor.
Okay, I finished the exam. You can tell me what's your concern, Miss Margaret.
Okay, doctor, I'm just wondering, what do I have exactly?
After I take the information from you and after examination, I think you have what's called chronic pancreatitis. You hearing about this before?
No, doctor.
Okay, this special gland in the abdomen. Sometime if there is any inflammation in this gland, it's cause abdominal pain and can cause also the new diabetic because you are diagnosed since 2 months new. For
Mm,
that, I need to do. I admitted you, and I will do for you investigation. Okay, I
mm.
need to do also for you blood investigation, stool investigation, and I need to imaging like ultrasound and CT for abdomen. Any another concern, Miss Margaret?
Doctor, well, I quite understand I have what you said I have, but
Yes.
why do you think I have this? Why?
See, Miss Margaret, there is many cause of this, the inflammation for this gland. Most of them, if you have what's called gallbladder stone, if there is a small stone in the gallbladder, it can moving and causing this problem in the pancreas. Sometimes some drugs and sometimes drugs and sometimes alcohol also it can cause this problem, Miss Margaret.
All right, doctor. So what will you do for me now?
I told you I will admit you and I need to do for you investigation, blood investigation, blood investigation and stool investigation, and I need to do also image investigation for you. Okay, and I need to refer to you for multidisciplinary team, including of the gastroenterology. Sorry, gut doctor. Sorry, forget doctor. Any other another concern, Miss Margaret?
Okay, doctor. So this current pain that I'm having, how will you help me? Because this is the reason why I'm here. It's because of the pain.
Yes, sorry for you, Miss Margaret, but I will give you analgesia now. For that, I will admit you and I will start for you analgesia and sorry, not analgesia. For I will start. I give you painkiller, Miss Margaret.
Okay, all right. Hopefully, I'll get better with the painkillers. Could you
Yes.
think? Are you not going to give me antibiotics? Since you said I'm having some inflammation,
What?
some antibiotics, doctor.
Not antibiotic, but I start for you analgesia and I will check what the cause of this problem, Miss Margaret.
2 minutes left.
Okay, okay. So you mean I don't need antibiotics? Is that what you said?
Yes, and right now, no need for antibiotic. But we need to do more investigation and treat it that according of this problem.
Okay, doctor.
Okay.
Thank you.
Any another concern, Miss Margaret?
I'm just worried that I'm just worried if I've got any sort of cancer, knowing that this is coming on and off. Could it be cancer?
See, I want to tell you, Miss Margaret, the cancer one of the possibility. Okay, but we need to confirm this by investigation. But
Mm,
from the information I take from you, I think it's less suspected. Okay, Miss Margaret.
okay.
Okay,
All right. Thank you, doctor.
thank you, Miss
Okay.
Margaret.
50 seconds left. You want to advise if you suspect something and you want to advise about it. The cause, for example.
I want you to stop now to drink alcohol and smoking, Miss Margaret, because this is increase your problem, Miss Margaret. Okay?
Okay, doctor.
Okay, thank you.
Okay. Let's start the examiner question. If you are satisfied with the history, you want to ask any question, you want to add any examination?
Oh,
Okay. You can start the examiner question, please, Dr.
all right. Thank you for the presentation. Okay, can you summarize your patient?
This is a 40 years old female. Now, in case of diabetic, in metformin, she came complain recurrent abdominal pain in epigastric area radiating to the back, associated with nausea and sometimes vomiting. There is no loss of weight, no jaundice. By examination, there is only tenderness in the epigastric area. Most probably, this patient, she has chronic pancreatitis.
Okay. So what is the most likely cause of chronic pancreatitis in this patient?
I think the most cause of the pancreatitis in this patient, alcohol. I think also about the gallbladder stone, but she ignored. There is no history of any jaundice or liver problem before, and I think also medication.
Okay, what type of medication do you think? Example of medication that you think can cause this?
I'm not sure if metformin, but really I'm not sure it's cause pancreatitis or no.
Okay,
But
so
I want medication because she started metformin. Yes.
okay, so what are do you think triglyceride can cause this? It's one of the causes of pancreatitis.
Triglyceride? Yes, sure. Yes.
Okay, so
Hyperlipidemia, yes.
yes, could you tell me possible secondary what are the possible causes of hypertriglycerides?
Maybe metabolic syndrome.
Mm-hmm.
Maybe familial hyperlipidemia. Dietary problem, dietary يعني unhealthy diet.
Mm-hmm. Okay, what are the possible complications?
Complication of pancreatitis,
Yes.
maybe cause a cyst, and maybe cause also cancer. Yes, cancer, and it can cause the cyst. Diabetic also complication from the pancreatitis. Yes, this is what I remember really.
Okay. All right. Okay. Any about are you aware of any surgical procedure in chronic pancreatitis?
Yes. First, we treated like by observation and management. Observation, and if not improve, if there is necrotic tissue, we can do surgical to remove it.
Okay. Any role of imaging in the investigation of?
Yes, we can do ultrasound abdomen, and we can do also CT abdomen to check if there is a cyst or the inflammation in the pancreas.
Okay. Anything invasive?
ERCP.
Okay. And what will you be looking for?
Necrotic tissue and obstruction in the dilatation in the dilatation of the, I think, small channel. Yes, I'm not. Yes, necrotizing tissue. I remember.
Okay. All right. Thank you so much. That's
Thank you.
that's all question I have. Thank you. Well done.
Okay, still for 50 seconds, so I will add some question from mine. Okay, Dr. Al-Huda, how to manage this patient?
I need to admit the patient.
Perfect.
I start for her IV fluid, painkiller,
Okay.
observation first. Yes.
Now, before all of this, what you want to do? You already mentioned to the patient.
Stop the medication that caused the problem.
No, no.
MBO, patient MBO. Uh,
Still need expert opinion, right? So you will
yes.
not do this by yourself. So
Ah,
what you will
okay.
do?
Referred for the gut gastroenterology.
Yeah, this is the time to say multidisciplinary team. Don't mention multidisciplinary to the patient. You can now say multidisciplinary team approach. Give me the name of the teams you want to.
Uh, we need maybe gastroenterology and surgery.
Perfect. And what do you
Maybe
think other team?
social worker.
Hepatobiliary, for example. Okay. The special nurse. Always remember those supporting the patient in hidden way. They are not a doctor, but they are still in the team. Physiotherapy, dietitian. Even dietitian here is important, right?
Yes.
Pharmacological or clinical pharmacist. You might need some antibiotics or medication. She should be on a replacement. So you can mention a lot of teams which are important, and at the same time you save the time. Okay. Now back
Okay.
to the management. Give me
Yes.
the non-pharmacological and the pharmacological and possible surgical.
And non-pharmacological, we
You
education
mentioned already.
counseling. Yes, we keep the patient, stop the smoking and alcohol, and I stop the medication. Pharmacological, I need the patient admitted. I keep her MBO, and I will start for her
Yes.
analgesia and IV
Yes.
fluid.
Yeah. Good hydration. Okay. So
Yes.
this is the way. Keep NPO, start good hydration and painkiller or analgesic, as you mentioned. Okay. Any pharmacological option in this scenario?
Antibiotic.
Yeah, sometimes it needs. Okay.
Uh, I don't
Particularly
remember.
if there is
Stone or no.
if there is evidence of infection, like as you mentioned, cholangitis or cholecystitis. But I think this is not the case because this patient is under a term of familial hyperlipidemia. I think so. That's Dr.
Mm.
Ayola, correct?
Yes, yeah.
Yeah. So what you want to do for the familial hyperlipidemia? Any
I
management
will
plan?
screening. Sometimes we do plasmapheresis for the.
Yeah, this is the way to answer. So first you have to investigate to confirm and to manage. Investigation, how you investigate patient with familial hyperlipidemia.
We will do a lipid profile, and we will
Exactly.
screening also the family.
Okay. What lipid profile you know? Let's go more deep just for getting more information, teaching purpose. What lipid profile you know?
LDH, triglyceride, and high density lipoprotein, low
Perfect.
density lipoprotein,
And
B, B,
one you're
beta
missing. Cholesterol.
triglyceride. Yes,
Cholesterol.
cholesterol.
Okay. This at least this is the most simple one. Maybe there's be two. I cannot remember even the name, but at least you have to mention the basic lipid profile to do. So triglycerides, high density lipoprotein, low density lipoprotein, and cholesterol. Next question: how to confirm the diagnosis
Of hyperlipidemia.
of
Uh,
familial hyperlipidemia?
it must there is family history,
And so,
and I'm not remember the number, but that's very high the lipid, but I don't remember the number.
okay, forget about the number. What the mode of inheritance? Is there a mode of
Mhm.
inheritance?
uh, Autosomal dominant.
Mhm.
Um,
Okay, okay, continue. So the management plan will be pharmacological
screen
option. Yeah, autosomal
uh,
dominant. So if there is inheritance as genetic, we will do genetic testing. The last question: how to manage? What you will give?
for
Not
what to
as a
for
specific
hyper
name. Give me the term of the medication you can use.
For what, doctor? For the hyperlipidemia?
Exactly.
Statin. We can start statin.
Yeah. So you'll start lipid lowering therapy.
Yes.
Might be statin, might even need some other medication, biological therapy like ezetimibe, some also other medication in the biological therapy. I cannot remember the name now, but there is a lot of options according to the type of the hyperlipidemia. And sometimes, as you mentioned, it might need plasmapheresis if there is symptoms. I think it's fair enough. 15 minutes questions. Dr. Ayula, now your comment, please.
Thank you. Well done, Dr. Oda. It was a nice presentation. History, very good as usual. Very good history as usual. Thought process good in terms of the diagnosis and the possible causes. Good. Honestly, apart from both of the things I would have loved to talk about, Dr. Basim have discussed it during the discussion. So it was good all together, except for possibly the drugs, medications that may cause pancreatitis. And that might include some antibiotics and some antibiotics. I think tetracycline can cause that. Then acetylprine can also cause that. Then some antiviral treatment. Some I can't remember the name, but HIV drugs also can cause pancreatitis. Okay. Then in terms, I was basically this treatment. Then anticonvulsant like the sodium valproate also can be incorporated in this. So basically, it's a good presentation altogether. I would say, well done.
Okay.
Okay, any specific management plan in this scenario you prepared while you read?
Yes, for this patient, what I was hoping that we discussed about hypertriglyceride, and it was in terms of when I told you that my father has had early stroke.
Exactly.
So
Yes.
I was thinking that maybe with that you might be able to see, okay, possibly it might be something that runs in the family that might have caused this.
Perfect.
That was I was and we could able to discuss about familial hypertriglyceride and as been said earlier, there is a familial cause and also secondary cause. For the familial cause, it's genetic causes, and it's autosomal recessive. Oftentimes, or somebody says so. Though sometimes it can be multifactorial, but when it is mono caused by specific by gene, it is autosomal recessive inheritance, and the non-secondary the secondary causes could include endocrine condition like Cushing syndrome, hypothyroidism. Also, it can also be caused by prolonged use of steroid. Okay, diabetes can be a cause and complication
Yes.
of hypertriglyceride, and also HIV itself. Then some anti-inflammatory conditions like systemic lupus erythematosus, rheumatoid arthritis. These are the possible causes that can cause.
ARCP. ARCP as well as a trauma can cause it.
Yes, can cause that as
Yeah.
well. And so, in terms of the complication of pancreatitis, there are a lot of complications of pancreatitis, although it can cause a pseudocyst.
Exactly. Yes.
It can progress to pancreatic
Abscess.
to abscess. Yes, it can cause it can also cause pancreatic cancer. Okay, splenic vein thrombosis can also occur. Diabetes, like we've said earlier. Then it can also be a cause of malabsorption of
Yes.
and which can progress to some mineral bone diseases
Vitamins deficiency.
and preferred the deficiency in this patient. So the complications are numerous, which possibly we can just mention one or two things. Though I think you were able to talk more. You were able to rule out some of these complications while you were taking
Yeah.
your issue, because your issue was quite good. And in terms of management, okay, it's multidisciplinary approach, okay, but the cornerstone is lifestyle changes. So I was hoping that you would talk more on the lifestyle changes, like even if no alcohol is allowable in this case, even though I take within allowable range,
Yes.
you are though you mention it, but you didn't emphasize how important it is that I
Yes.
should stop alcohol even if it's within allowable range. I should stop
Okay.
alcohol. Then
Mm.
smoking is also, of course, in smoking you should cancel every disease. Then you didn't check my weight, which is quite important. Yeah, check my BMI to know
Okay.
if I am obese, and you could also cancel in that direction. To, weight loss, of course, it can bring down, it can help in some of these, in most of these metabolic condition. So basically, it is lifestyle counseling. Then refer to multidisciplinary team, and of course, you admit IV fluid, very important to ensure that what the pancreas is well perfused.
Mm.
That will also help in the diabetes control. Okay, and then painkiller, possibly the NSAID, anti-inflammatory, and also
Mm.
there's room for steroid in this because of course it's an inflammatory thing, room for steroid, and because it's a chronic pancreatitis, this patient will benefit from ERCP, which you mentioned, and if there's need for MRCP, we'll go ahead to do that. Then that is if it's a gallstone causes, of course, but in this patient, it's most likely to be a family a metabolic thing that is causing for this middle-aged woman. So and in terms of the treatment, basically, of course, is starting. They start starting in this lady, and if you've not achieved if start depending on the level of the triglyceride, really, if it's quite high, because we can take mild, moderate, severe. If it's quite severe, then we don't do statin, we do fibrate. Is specific for hypertriglyceride. But if it's still moderate, then we can start with statin. If it's not controlled, we add fibrate to it. But fibrate is the cornerstone in the management of hypertriglyceride, triglyceride. So basically, that's it is. Well done, Dr. Ida.
Yeah. Thank you, Dr. Ayula. Very well preparation of the topic. It was concise to the topic. However, it's not that much details to be aware about all these things. For basis wise, you will not reach to this extent of question anyway. I just confirmed, Dr. Ayula, there is type of the familial hypertriglyceridemia.
Mm-hmm.
It's autosomal dominant.
Okay.
So yeah, there is types, and we don't know what type we have in this scenario.
Mm-hmm.
But maybe there is another type with autosomal recessive. We can more research about it after the lecture, so we can update it to the WhatsApp group. Okay. The other thing, I will talk now about the performance of Dr. Al-Huda. Yeah, the topic already we discover most of the points and we answer most of the questions. Back to the performance, Dr. Al-Huda really today she followed the approach which I like properly from the history and examination. The history, the complaint analysis, the relevant system. But I'm not sure if she asked about difficulty of swallowing. Did you ask, doctor? It's one of the GI questions you have to ask.
No,
Yeah.
I'm not
Okay.
asked.
Yeah. Remember it. Maybe in this scenario it doesn't matter, but maybe in another scenario it will matter. Okay. So
Yes.
remember the mouth sores you ask change of bowel habit difficult. You can bring it from up down. So from the mouth sores, difficult swallowing, and the tummy. You have a lot of things in the tummy you have to ask about. Tummy distension, discomfort, tummy pain, a change of the bowel habits. You
Okay.
forget as well one of the important systems while you ask about the systemic review, the skin rash or musculoskeletal. Some
Yes.
patient they can present or they might present with a skin rash. It's not rash per se, but it's like skin tags or something fatty in either the xyloma or the xylosma. some of patients they might have these things, right? Some in the
Yes.
tendons. I cannot remember exactly what type and what the manifestation. Okay, back to the constitutional symptoms. You ask very good question. Any jaundice? It's a very important question as constitutional symptom, and it might be related to the case. Why? If there is jaundice, Dr. Al Huda, what's your first differential?
I think also about autoimmune hepatitis is sometimes there is autoimmune pancreatitis and
Okay.
gallbladder, gallbladder stone, primary biliary cirrhosis, all
Yes, all these
autoimmune.
can be there. On the top of them, what you should
Go-
think if you have jaundice, loss of
Gallbladder
weight, loss of appetite, plus tummy pain.
cancer, liver cancer.
Exactly, yes. Not only liver, any biliary duct cancer like cholangiocarcinoma or even the pancreatic cancer. Okay?
Okay.
Yeah, add to them the as infection, ascending cholangitis, or any infection in the biliary duct might lead to the jaundice. But jaundice with constitutional symptoms, you might or you have to put differential diagnosis of cancer, particularly hepatobiliary or pancreatic cancer. Okay, back to the other constitutional, you rolled out lumps or bumps, any change of the weight, night sweats, night fever. All this question makes sense to roll out the most serious related differential diagnosis. Then the systemic review, I believe you did it in perfect way. From the head, headache or neurological numbness, everything you ask about, any intolerance to the weather. Why it's important to ask about the weather here? Because pancreas, one of the endocrine system, so it might be associated with thyroid or other endocrine pathology. Okay. Then the chest pain, awareness of heartbeat, short of breath. You will skip the GI system and you'll ask about genitourinary. And the good question you ask any change of your water work to the dark color. What do you think the importance of this question?
Gallbladder stone.
A
I
change
look.
of no, a change of the water work color being dark.
Yes.
Yeah, jaundice.
Yes.
Exactly. Yeah, increase the bilirubin and the urine turn dark, right? Then the
Yes.
musculoskeletal system we already mentioned earlier. The social is very important. I want to stress in this point, Dr. Al Huda. Never ever you have history or family history in a condition and you analyze it and you didn't be sympathetic or empathetic with her. She told you, I have, yes, the good question also. You ask her about any condition related to the tummy. She said, no, but you insist and you ask again, any family issue I should be aware of? She told you, yes, my father had a clot. So you have to stop here and think why her father had stroke. The first question, what do you think if you have a family history of stroke and you have the patient with you? What is the first question? Dr. Ayul already mentioned.
Yes. I must ask about the age of the patient
Exactly. This is the
because if he
first question.
young, I'm thinking about like blood disease or
Yes,
hyperlipidemia. Yes.
I believe this is the clue of the case. So, family history of blood clot. At what age? Oh, doctor, he was at his 50s or 40s. So it's something weird, right? I have to know what is the outcome, what happened with him. How is he now? Whatever
Okay.
yeah, you don't know what happened, but you have to ask. You know, it's one of the welfare points. Her father had already stroke, or I don't know, it was a stroke, right? Yeah, or blood clot. I don't know what in which system, but uh, I think it was the stroke, brain, right, Dr. Ayula, or a clot in his heart.
No, she said
Stroke.
stroke.
A
Stroke.
stroke. Yeah, so I should know what about her father right now. How is his current condition? Is he fine? Is he at home? Is he diseased? Is he anything disability happened to him? Then I should be sorry for her. For example, he
Okay.
is died after this event. Oh my God, I'm so sorry for your loss immediately. Okay, and you should know again at what age he had this stroke. You
Yes.
finish the family history. You can confirm again any other family history of blood clot. If you want to suspect something running in families, in any of your family member, siblings or offspring, your brothers, your sister, no doctor, they are fine. Only my father. You can ask even now. Did he had any diagnosis? Did he has any diagnosed or did he diagnosed or any condition I should be aware of? She might give you the clue. Believe me, she might tell
Okay.
you, yeah, something in his lipid. So you get the case. If he's
Okay.
kind surrogate, of course. But if not, just skip it. Go to the next, the travel history. The you ask here about the female history, which is good, but you didn't ask about the age of if you suspect something related to the pregnancy. The good thing also you ask about the pregnancy. Is she pregnant right now? You have to ask this question whenever the patient and the childbearing age and she's having, for example, tummy distension or tummy pain. Just rule out the pregnancy, okay?
Okay.
Then, yeah, you can ask about any sharing needles. You have good time to ask about all HIV questions. As Dr. Ayula mentioned, some of the antiretroviral medication can lead to the pancreatitis. Any
Okay.
medication, by the way, you asked about past medical history earlier, which is good. I am diagnosed recently with diabetes. Any medication, how is your blood sugar control? How is the last 3 month reading of glucose? Do you have any hypoglycemia or low blood sugar reading? Be ready to ask and to analyze the diabetic status of the patient at any scenario, not only in this scenario, particularly those with type 1 diabetes and they have long standing diabetes, more than 20 years, more than 10 years, when she was or he was young or a childhood area or a childhood age. You have to analyze the diabetes and the complication of diabetes. It's not in this case. You're lucky that it's recently diagnosed, but some cases it might be since long time. Try to explore other medication. Are you in any on any medication, any over-counter medication? You might have some event or medication. Occasionally, patient talk recently for infection, for example, or for something herbal, and it might be the case. So try to explore his medication. If you want to do one question collectively, will tell you about, you can tell her, show me your medication list, and she cannot hide any medication. By the way,
Okay.
every case scenario in PACES, they might give you a big list of medication just to correlate one of them to the condition. You will be lucky to say it, one of the differential, and it might be the case. So you will not lose anything if you mention it as a differential, or even it might be the case in this scenario. Okay? But not of our scenario, but you have to be ready for such scenarios in the exam. Then
Yes.
smoking, you address it well. The alcohol, you address it well, especially if she's drinking less than the limit. But in this scenario, as Dr. Ayola mentioned, we should stop drinking alcohol until she's controlled. Okay.
Yes.
The second or the third question here related to the alcohol as well. If you have patient with limit or within the limit drinking, you have to ask her, are you binge drinking? Sometimes, yes, she is drinking with the limit, but at the occasions or at the weekend days, she drinks a lot, binge drinking. And you can say this is the cause of her pancreatitis. It might be the case of acute pancreatitis after heavy drinker or heavy drinking, okay?
Okay.
Yeah, the last thing, the job. You missed the job totally. You didn't ask about her job, the impact of her condition on her job. Don't
Yes.
ever forget that. Do you smoke? Do you drink alcohol? Do you drive if there is vision issue? And what's your job, the impact on your job? Fortunately, you have 3 minutes extra after the examination and the history. So something is missing. I guess one of them was the job or the occupational history. And always remember the question of, are you binge drinking or do you have any binge drinking last? Okay. The
Okay.
examination steps, of course, you did great starting from the vitals, blood pressure, If you suspect dehydration, you can ask about posture hypotension, the pallor, the jaundice. In the hand, you can explore also the skin ties, as I mentioned earlier, and even at the eyes angles for exanthoma.
Yes.
And some cases also, I think, in the cornea, there is corneal, I think, something like arc, corneal arc, something like that. I'm not sure, I'm not refreshing about this topic, but I think there is a case with the corneal arc or change or discoloration. Anyway,
Okay.
back to the examination, the abdominal examination, full abdominal examination you have to do. Add to them the lymph node examination. Okay, if you suspect cancer, you have to do at least offer examination of the lymph node, particularly the axillary one, and offer the inguinal because it's embarrassing some way. Okay.
Yes.
Yeah, the topic already discussed by Dr. Ayula. I will just add one point as a complication. Yeah, the question of the complication. Remember always, whenever you are talking about complication, I wrote in the chat because you can systemize your answer. So you can say acute complication or chronic complication. He will ask you, wow, good and impressing answer. So what are the acute complication? You can say acute pancreatitis, stone, right? Or
Yes.
even in some patients, sepsis, septic shock, extra GI manifestation like ARDS, ventilation, okay? For the
Okay.
chronic one, you can say, as you mentioned, cyst, abscess, even the endocrine or exocrine function might be affected without naming even them. But one of them, the post in the top of them, diabetes and malabsorption, right?
Yes.
So be smart before starting answer. And if you are stuck, you don't know or you don't remember the complication per se, you can divide your answer, categorize them, and start to mention or enumerate whenever and whatever you want to say. Okay.
Okay.
Okay. Thank you, Dr. Huda. Please type your scenario for Dr. Ayula.
Okay, doctor.
Let's read the comment. You have any question before Dr. Al Huda? You have any question? By the
Doctor,
way,
I want to
well
ask
done.
about
Okay. Yeah. Okay.
I
Continue.
want to ask about the if I finish the examination, I can
Yeah.
ask what I forget of question because I remember
Yes,
many
definitely.
points, but okay.
You have 15 minutes with the patient. Whenever and whatever you did, you want to ask to do, to examine, to take history, to advise. And the advice is very important. Listen, as I asked you at the end, do you want to give her some advice? If it is related to the alcohol, you can stop the alcohol. If she is heavy drinker, you can tell her moderate your intake. If it is something else and you want to advise about the binge drinking, you can tell her stop binge drinking. So it's something you can create while having good time. So you can advise after, of course, asking all concerns. You finish the concerns. Now the time to give her some advices.
Okay, thank you.
Okay, thank you, Dr. Rahda. Any question from Dr. Ayula? Yeah,
Hello.
No, please, no question.
okay.
Thank you.
Yeah, try to stop jargons or try to avoid jargons, Dr. Huda. You are mentioning abdomen, which is tummy. I wrote some of them in the chat box so you can read. Also, radiating to the back, you can say it goes to the back or traveling anywhere. The vomiting, you can say, if, are you feeling sick? The vomiting, sorry, the throwing up, and the nausea is feeling sick. Jaundice, you
Mm.
can say anyone told you are yellow, your eyes looks yellow, and so on. Whenever you have medical term, try to simplify it.
Okay.
Hello,
Okay.
Dr.
Yes,
Dr.
Dr.
Bassem.
Maida.
I'm
Yeah.
just asking, what is the cause of admission in this patient? Why
Admission.
yes, why we admitting the patient?
The severity of the pain in this scenario, which is was already discussed,
Mm,
more than 5, so patient need to be under good analgesia, right?
Yeah.
This is
So
one of the criteria.
severity of the pain, how much
Yes.
is it? 10 out
More,
of 10 or
no,
more
more than
than
5.
5? But can we manage it at home by analgesia as well?
Okay, let's assume this patient came to you with this features of pancreatitis. Do you think he's safe, or it is safe to discharge him at home and to give him medication? Have you ever seen
If chronic,
patient with pancreatitis?
we have criteria for admission for a patient with chronic
You
pancreatitis.
mean criteria,
Yeah.
the score, Ranson and so on, right?
Yeah. So
So at least what
in
you will
this,
do,
mm,
at least what you should do before deciding to discharge him, what you should do.
I'll give her good analgesia if she is, because I didn't found any cause for keeping her NPO. And now the good practice is to start feeding early in pancreatitis.
Yeah.
One of the, sorry.
Yeah, go ahead.
Okay, so this is one of the criteria of new criteria for pancreatitis, to start feeding very early
Yeah, as soon as
and
possible. Yes.
as soon as possible. And
Yes.
there is criteria, specific criteria for keeping patient NPO, even if the patient admitted to the hospital and still we are thinking that this patient can take orally, we'll give him orally from the start,
Yes.
unless the patient have very severe pain, vomiting, and
Yeah,
a lot of
exactly.
there is criteria for that. So in this patient, we need to assess the pain and how it is different from her basic pain, because she has chronic pain. This pain for a long time. Is it different from her chronic pains? I mean,
Perfect.
acute and chronic. If it is acute and chronic, this is indication for admission in the hospital. But if it is like her similar pains and she was managing at home, but now she's concerned about this pain, we still can give her analgesia and we staphylating her to be discharged at home and follow up in the clinic or hospital at home, or any or SDIC clinic or any clinic as outpatient. Not criteria for admission. She has no sign of fever. So the criteria of admission, I can't see there is a criteria in this case. The admission, to be honest, the pain itself is still we can manage as outpatient, and still we can follow her as outpatient.
Okay. Thank you, Dr. Maida. Very nice comment, of course. But let's talk about the point of a gray zone in this scenario. You don't know even the cause of her condition. So at least you will run the investigation, admitting until running the investigation, confirming the diagnosis. Okay, later on, yeah, she might be
We still
discharged.
investigate that. We still investigate that, like
Yes,
referring to SDIC clinic. So
agree.
SDIC is a same day clinic. So this patient can come to same day clinic and have her investigation and go home. It's still,
Yeah, so you're insisting to discharge this
I
patient.
mean, like, because
Okay,
nowadays,
I will not myself
nowadays
decide.
they are really insisting to keep patient in the hospital. They need like a lot of criteria to make this
Yes,
patient is specifically need the hospital. If he is not need, because they have a lot of
yes.
yeah. Um,
I
uh,
agree with you, Dr. Maida, by the way. I agree with this point. But I am not the one prepared the case. I don't know, is it for admission, Dr. Ayula? Because for me, if the patient is having a scale of pain 5 and above, I will admit. But I don't know the
Yeah.
case itself. I told you it's
I
a
think
case of
it's for
debate.
admission, really. Pain of 8.
her pen 8. Okay.
Yes.
Yes,
Yeah, so this
maybe
is
there
as
is issue.
particularly for this
Yeah, yeah.
scenario. But
Yes,
maybe in another
Mm.
scenario, the pain is okay, patient comes and goes. Every time he's taking painkiller, he's improving. Yes, you can refer to the gut clinic or the gastroenterology. They can run the investigation in the outpatient clinic. But you have to give a wise decision, either admission or no, according to your history, of course. But in this scenario, particularly, patient need to be admitted because of the severity of his pain or
Mm.
her
but
pain.
It's,
Dr. Maida, sorry, but in our really life, in, we not discharge any patient
Mm.
if we suspected acute pancreatitis.
are you suspecting
Because
acute
they came with
pancreatitis in this
severe
patient?
pain, Doctora.
Yeah, let's. Yeah, I said again.
Is it acute
She said,
pancreatitis?
yes,
No, it
she
might be
said
acute on top
three
of
days.
chronic. Yeah,
Yes, she said since 3 days increase, and
yeah,
she
the
said the
severity. Yeah,
score 10. For that, sure, I will admit this patient.
yeah. So
If
it's
her pain,
area
yeah,
of
Yes,
debate again.
totally agree.
yes,
Yeah,
If her pain is very severe, then yes, we will admit this patient. But we have
yes.
criteria for admission. I mean,
yes, I agree with
Okay,
you,
no
Dr.
problem.
Maida.
Thank you. Thank you for your comment, Dr.
Yeah.
Ahmed.
yeah, we
Oh,
have
if
a BISAB score. If we do BISAB score, and
Mhm.
it, the BISAB, I didn't remember exactly how number, but if BISAB score is in a specific number, so we will not admit. If BISAB is above, then we will admit the patient, and we'll
Okay.
see the risk criteria as well to keep the patient NPO or no.
Yes,
We
I
just
agree with you.
use this criteria.
Okay,
Okay, thank you.
if you can share this score, Dr. Maida, even here or in the WhatsApp group, so to be also
Try to find it. Yeah.
refreshed. Okay, I heard about it, but I'm not aware about the component. Back to the debate. I said this is a case of debate. Some patients need to be admitted, but to be safe in the decision, if you have any conflict about either to admit or discharge, you can answer in a diplomatic way. I will admit this patient to run some investigation to confirm my diagnosis, and I will reassess the patient back. It's very safe, diplomatic, and you will get the mark for this decision. You didn't admit him definitely to the wards or ICU or whatever. In the same time, you didn't discharge him before running the investigation and confirming the diagnosis. Okay, this is the best way to answer a case with debate like our case today. Thank you anyway, Dr. Maida. You raised good point, and we learn also from this point. Dr. Ayula, your scenario, 35 years old, male patient, John Smith, again, as usual, complain of short of breath. I'll try to read the comments quickly until you're ready. Back to my comments, I will start. I'm always typing such issue just to remind others and remind myself. I don't intentionally means to distract the surrogate or the candidate. So if you are participating, don't look at the chat box. But sometimes I'm writing to remind myself after finishing the case. Sometimes I forget the comment or the area of improvement. Like in this scenario, any further health problem, please try to ask about the current condition. How's your father right now? And be sorry if he's lost or affected by the condition. The emergency, yeah, Dr. Al Huda, the best way to introduce yourself, please. Don't put a word or unit. Just say, I am Dr. Al Huda, one of the doctors here. You mention I
Okay,
am one of the doctors in the clinic, and the patient already presented to the emergency. The only impression or the first impression to the examiner, you didn't read your scenario well, right?
okay, okay,
So the patient in the emergency, I am one of the doctors here. Whatever you are, whenever, wherever, it is one of the doctors here, regardless the position, regardless the ward or the unit. Okay, no,
okay,
the radiating I mentioned, radiating travel or goes. To be sorry, I mentioned tummy. You can say instead of abdomen. Diabetic
okay,
history, sedentary lifestyle. Yeah, this is one of the possible cause. Patient is always on the junk food or fast food. He might have hyperlipidemia or she might have hyperlipidemia plus alcohol, of course, one of them. Acute and chronic as a complication, you have to remember, put it in your system. Endocrine, exocrine complication, you can mention diabetes, malabsorption. Yes, malabsorption is very important as a chronic. So the patient will have, what do you think if he has or she has malabsorption? What the bowel will be, Dr. Al-Huda?
What's
The bowel,
what's
the
your
bowel.
name?
If the patient is having malabsorption as a complication, what the bowel habit will be?
She has diarrhea. Diarrhea,
And
offensive. What?
exactly, yeah, what type of FDRA? Continue, yes, yes, this is my
Yeah.
question.
Staturia. Staturia.
Okay, and it would be,
What?
it would be, is it flashable?
No, no, not flushable.
Yes, exactly. So it's a non-flashable one, and it might be large amounts. Okay. The causes of admission, yes, we mentioned chronic pancreatitis. We talk about this in widely. Autosomal dominant, I agree with this because I search about phenofibrate, so it depends on the type of the hyperlipidemia. Mesalazine, I remember also one of the causes can cause pancreatitis, or one of the medication can cause pancreatitis. Differential of chronic abdominal pain. Good question, Dr. Rabia. I like this question. Oh, Dr. Rabia, I want to answer it because you asked it. What is or what are the cause of chronic abdominal pain, Dr. Rabia? You have to think. Dr. Rabia, can
Chronic liver
unmute yourself, Dr. Rabia? If not, Dr. Al-Huda, you can answer this question. In basis wise, what are the common cause of chronic abdominal pain?
uh, maybe chronic liver disease. We put also if the patient he have sickle cell anemia, one of the cause.
Okay,
I
this is,
thinking also about
yeah,
Mediterranean fever. I think
perfect. Yeah,
about also
these
progeria.
are the causes. Remove chronic liver disease. The chronic liver disease will present with distension or discomfort. He will
Okay,
have tummy pain if he has spontaneous bacterial peritonitis, for example, if he has other complication like tense ascites or infection. Okay, but in the common in cases, familial Mediterranean fever and chronic
progeria,
pancreatitis and
progeria,
acute intermittent porphyria. One more.
sickle cell anemia,
Okay, one more. Still, I need one.
angioedema.
Perfect. This is the one I waited for. Add to them the DKA if the patient is diabetic. And yeah, sometimes the irritable bowel, it's not irritable and inflammatory bowel. Yes, sometimes they are presenting with tummy pain. But of course, you will have other finding of manifestation of the disease, like diarrhea and bloating. Okay. Pancreatitis pain need narcotic, of course. Thank you, Dr. Tahani. Dr. Wisa, more than 7 that indicate admission. It's okay. For me, I want more than 5. Sorry, I joined late. What was the diagnosis? It was familial hyperlipidemia complicated by acute or sorry chronic pancreatitis. Yeah, Dr. Maida shared the early feeding in pancreatitis. Let's read it quickly. It would be early feeding is recommended within 20 to 48 hours as soon as the patient can tolerate the food. Yeah, start the low-fat solid diet or soft diet. No need to delay for clear liquid. The early feeding reduce the hospital stay and complications. Severe acute pancreatitis. This I think it should be MPO, not possible within. If oral feeding is not possible within 72 hours, start enteral nutrition via nasogastric tube or nasojejunal tube. Enteral feeding is preferred over the para, para, parenteral. You mean TPN, right? Yes, parenteral. Yeah, parenteral nutrition. As it is preserved gut integrity, reduce the infection and mortality, lower the bacterial translocation, chronic pancreatitis also. No need for MPO unless there is complication like severe pain, pseudocyst. Focus on the nutritional support, pancreatic enzyme replacement, and fat-soluble vitamin supplements. Perfect. Yes, familial Mediterranean angioedema, one of the differential bases. Let's start second scenario. So we can call Dr. Ayula ready? SGLT2 also inhibitor. Thank you, Dr. Nahla, for SGLT2 inhibitor, one of the causes. ARCB as well. Yeah, I think I covered all comments. Ready, Dr. Ayula?
Yes, please.
Yeah, here you go.
Okay.
Hello.
Hello.
My name is Dr. Ayola. I'm with the doctors here today. Can I confirm you are Mr. John, 35 years old?
Yes.
All right. Thanks for coming to see us today, Mr. John. We are here to discuss about your health, okay? And possibly arrive at the diagnosis and discuss the treatment plan. Is that okay?
Yes. Okay.
All right. Could you tell me what's been going on, Mr. John?
I don't know, doctor. In this morning, I have, when I go to my work, I have sudden severe chest pain,
Mm.
and then I have shortness of breath.
Oh, I'm so sorry that because that must have been a scary situation for you. Mr. John, may I ask, if I got you right, you said you had a sudden chest pain
Yes,
and
yes,
shortness of breath.
yes.
Okay, how long ago was this?
What?
How long ago did this happen?
This is, I think now since 3 hours, doctor.
3 hours ago. And how do you feel now? Are you still having the pain?
No, the pain improved, but still I cannot take my breath.
Okay, all right. And could you tell me more about this pain, Mr. John?
I don't know. First time, it's sharp in the right side of my chest.
Okay, did it go anywhere?
No,
Okay, is there anything that you think might have brought up this pain?
the pain, there is no pain now. It's stay for short time, then gone. But the problem now, I complain shortness of breath.
Okay, all right. I was just saying that have you ever had this before?
No, this is first time.
The first time. And is there anything that you think would have brought up this pain?
And no, since 3 hours, I have same shortness of breath.
Okay, all right. So this shortness of breath, so it's been ongoing for the past 3 hours. Okay, is it getting
Yes.
worse?
I feel yes, yes,
Hmm? Okay, is there
yes.
anything that is making it better?
No, I'm not obsessed.
Okay, all right. Are you coughing?
No,
Okay, and do you have any leg swelling, any leg
no,
swelling or pain anywhere in your legs?
no.
Okay, and you said this is the first time you're having this, if I'm right?
Yes, this sharp pain is first time.
Okay, and what about the shortness of breath? Is this the first time as well?
Uh, See, I have shortness of breath before,
Mm-hmm.
maybe of 6 months. But when
Okay.
I do heavy exercise, I have shortness of breath. But not like this. This is severe and increase. Not
Oh,
that simple. When I rest, it improve.
okay. So what were you doing when this pain started?
N- Not what's pain. Now this pain,
I mean, what were you doing about 3 hours ago when the pain started? I mean, the shortness of breath got worsened.
I go to my farmer. I work in the farm and I go there. I start to work. Then
Mm-hmm.
I have this severe pain and shortness of breath.
Okay, and when you did what did you do after this happened? Did you do anything?
No, I think when if I take rest, I will improve. But I'm not improve. For that, I came directly to the hospital.
Okay, all right there. So I'm so sorry about this. The last time you had I mean, you said you've been having this for the past 6 months. Have you ever got it checked?
What?
Have you ever get it checked? Has it been checked?
No, no, I'm not go to the hospital.
Goes to the
No,
hospital. Okay,
no,
all right. Have you got any leg swelling?
no, I'm not observed.
Okay. Have you got any? How many pillow do you sleep with at night? Are you able to
No,
sleep without pillow? Yeah.
no, no, doctor, no.
Okay. And do you feel as if when you lie down at night, you're having shortness of breath?
No, no,
Nothing
no.
of such. Okay.
With heavy, only with the heavy work, I
Mm,
have this shortness of breath. When I rest, I improve.
okay. When you wish to improve, and okay. And do you feel any when this happened 3 hours ago? Do you feel any lightheadedness?
No, no,
Any
no,
sweating?
no,
Did you vomit?
no,
Were you feeling sick during the period?
no, no. But I feel I cannot take a breath only.
Okay. And are you aware of your heartbeat, Mr. John?
I think it's increase. I feel it's increase.
Okay. Oh, I'm so sorry that you're feeling this way. Okay. And do you think it's regular?
Yes, yes.
Okay. Did you have any faint during this when this happened? Did you lose consciousness at any time?
No, 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 no,
Okay. All right. Okay. Have you got any headache?
no.
Any visual issue?
I have a problem in my vision, but since long time.
Okay. Could you tell me more about this?
I'm not see well. For that, I wearing glasses.
Okay. And did you see the doctor? Did they say anything about it?
No, really. I go only for the doctor. He examine my eye and he give me this glasses.
Okay. Is it that you cannot see something far or something near? What exactly is your vision like?
I'm not remember.
Okay. All right. Have you got any difficulty with swallowing?
No,
Okay. And have you got any numbness in your face?
no,
Okay. Any weakness in any part of your body?
no.
Okay. And have you got do you have any joint pain?
No.
Any
But I
rash?
have back
Okay.
pain.
You say
I
what?
have back pain.
Okay, you have back pain. And how long ago has this been ongoing for?
Uh, since long time, but not continuous.
You say what?
Not continuous pain. Sometimes this pain came, but in my back.
Okay, I'm so sorry about this pain. Is anything that on a scale of 1 to 10, how will you rate this pain when it comes?
I give 3.
3. Okay. Is there any time of the day that this pain is worse?
When I working hardly, I feel or lifting heavy object, I feel pain.
You feel pain
And
when you
I
lift.
take analgesic. I take painkiller. I improve, doctor.
Sorry, please. I need to. Sorry, please. Please go. I'm in a meeting, please. Sorry, I'm so sorry. Okay, this pain goes with analgesic with painkillers, please. Did you say
Yes,
go with painkillers? Okay.
yes,
And
yes, yes.
okay, is it worse in any time of the day?
No, no, no,
Any swelling in your back?
no,
Okay. Any numbness around your pelvic? I mean, around
no,
your. Any?
no,
Do you have
doctor.
any numbness? Okay. And
No,
any issue with your bowel?
no.
And what about your water works?
It's okay.
Okay. Have you got any tummy pain?
No,
Okay. And have you got any lumps and bumps in your body?
no,
Any fever?
no,
Have you lost weight?
no.
Okay. And this okay. Just a bit question about your medical history. Is there anything that you think have you managed for any medical condition, Mr. John?
No, 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 no,
Okay. And are you on any medication?
no.
Okay. Have you got any family history of any medical condition?
Uh, no, but my brother, he's died when he young.
Oh, I'm so sorry for this, Mr. John.
He have a sudden death.
Okay. And did you know exactly what happened?
I'm sorry, but because he lived in another area for that, in another country, for that we not know. They only informed us he collapsed sudden and he expired.
Oh, I'm so sorry, for this, Mr. John. Are you on any medication right now?
No, only painkiller, doctor.
Only painkillers. Okay. And how has this condition affected you?
It's sudden, doctor. Now, it's sudden. Only 3 hours. I don't know. It will continue with me.
Okay. But I mean, in terms of you've been saying you've been having this shortness of breath for the past 6 months, if I'm right.
Yes,
Okay. All right. And what do you do for a job?
I work in the farm.
Okay, in
I'm
the farm.
farmer. Yes.
Okay. Okay. And do you work with chemicals?
No.
Okay. All right. Thank you for allowing me to for speaking with me today, Mr. John. Okay, I would want to examine you if that's all right.
Yes. Okay.
Okay, so I will check your vitals, your pulse, and your blood pressure.
Okay. I will give you one picture, doctor, for my. You will examine my hand.
Yes, I'm examining your hand here.
I put one picture.
Okay.
Okay.
Trying to look at it. Yeah. Okay. All right. Thank you.
Okay.
All right. So I'm checking your blood pressure.
It's 130/50.
Okay. And the pulse rate, is it regular?
Regular.
Regular pulse rate. Okay. And okay. So I want to examine your chest. I want to examine your and your height first. Any pallor?
No.
Okay. Examine the mouth for cyanosis.
What?
Cyanosis in the mouth for
No.
cyanosis.
No.
Okay.
No.
Okay. So I'm checking your the oxygen saturation, and then I'm going forward to examine your chest. Any scar in the chest?
No.
Okay. So the heart I'm checking for the apex beat. Any, is it enlarged? Is it displaced?
Displaced. Yes.
Displaced. Okay. And I want to listen to the heart sound.
There is diastolic murmur in the aortic area.
Does it radiate anywhere? Does it radiate?
No, no, not
Okay.
radiating.
And
It's
when you lean
diastolic.
forward, is it become louder?
Yes, increase.
Increase when you lean forward. Okay.
Yes.
All right.
Yes.
So I want to examine the chest as well. Okay.
Yes.
The respiratory rate, and as well check for the expansion. Any reduction in expansion?
Degrees in expansion in the right side.
Up on the right side, all through. Which
Yes.
side is it? Upper or lower or middle? Everywhere?
Lower part.
Lower part.
Yes.
Okay. Is it trachea central? Totality of the trachea?
Yes. Now trachea central. Yes.
Okay. And any I'm listening to the base of the chest. To the base of the chest.
Yes. There is degrees air entry in the right lower zone.
The right lower zone. All right.
Yes.
Okay. All right. Thank you for
Okay.
for allowing me to examine you. Have you got any
Okay.
concern?
What?
Have you got any concern?
Concern. What I have, doctor?
All right. Thank you for speaking with me today, and thank you for speaking with me. So from all that, from our conversation and all that we have discussed, okay. Sorry, please. I just want to look at the. Okay, from the conversation and all that we have discussed and the findings that I've done, examination, looking at your end, and but by the way, Mr. John, have you ever had any broken bones before?
No, no.
Okay, all right. So I'm suspecting that you might be having a condition that is called possibly Marfan syndrome.
Yes, yes.
Okay, and
It is serious. It's
it's
serious.
yeah, it's possibly a genetic condition, and oftentimes it's something that could be serious because of the condition that comes with it. Like you said, the breathing problem that you are having now, the problem that you are having now could be something serious. Okay, and that
Okay.
may explain the chest condition that you have. Okay,
Okay.
the heart. Okay, when I examine you, I notice that you have some abnormal sound in your heart. Okay, this may explain
Okay.
that, and it may also explain the vision that issues that you are having. Is that all right,
Yeah.
Mr. John?
Yes.
By the way, Mr. John, do you have any learning difficulty?
What?
Do you have
Learning?
any difficulty with learning?
I'm not go to the school. I only farmer. I working farmer
All
since
right.
child.
Oh, I see, I see. So possibly that might be what might be going on with you, Mr. John, because it's a condition that affects multiple parts of the body, the joint, the bone, the joint, the valve, the heart. Okay, it affects some special protein in the body, and that might be what is going on. But so I want to admit you because of this breaknesses that you are having. Okay, because I think you might be
Okay.
having one of the complications
Okay.
might have set
Doctor,
in.
my children will have same problem.
Well, Mr. John, there's this. Well, sorry to tell you that there's a possibility that your children might have this sort of problem.
Yes.
Okay, there's a chances that they may have this kind of condition, Mr. John.
Okay.
I'm so
Okay, doctor.
sorry, but have any one of them had any symptoms, anything that is concerning about them?
No, still no.
Okay, I will advise that we might refer them to the genetic clinic so that they can have a conversation about this. Is that okay?
Okay. There is a treatment, doctora?
Well, for this condition, it's usually a usually it's not. I'm sorry to tell you that it's not curable, Mr. John. But we can manage the complication if it's treatable, depending on the kind of treatment that you have that might be going on. In terms of your eyes, we will refer you to the multidisciplinary team, which will include the doctor that deals with nerve, those that deals with heart, those that deals with bone, and also those that deals with your heart, where they will formulate a treatment plan for you in accordance to your needs, basically. But for now, we want to admit you to sort out this sudden breathlessness that you have. And I want to do an urgent heart scan for you, okay?
Okay.
And also do a tracing of your heart, do some special tests to check your heart, and then we can take it up from there. Is that okay, Mr. John?
Okay, thank you, doctora.
Okay. Sorry, I lost the timer when she was posting the picture. I made a post, but I didn't resume again. So I guess the time is up. Let's start the examiner question. Dr. Al-Huda, you can start.
Okay, you can tell me what's the differential diagnosis? What's the diagnosis, doctora, in this case?
Okay, for this case, I'm thinking of a possibility of a Marfan syndrome in this
Yeah.
patient, okay? And
Okay.
because of the I'm thinking of Marfan syndrome because I just spoken. Let me summarize first. I've spoken to a young 35-year-old man with sudden onset of shortness of breath, okay, and
Yeah.
which though I've been having background shortness of breath, but this one started about three hours ago with chest pain. He has
Okay.
some on examination. He had some muscular, some some skeletal deformity in the chest,
Yes. Yes.
and also had some visual issue.
Yes.
So putting all this together, I'm suspecting that I may have a condition called Marfan syndrome.
Yes.
And another possibility would be metabolic disease like homocystinuria can be a possibility here.
Yes.
But I will expect that this patient will have good the intelligence will be high, it will not be affected. There will not be any form of learning difficulty in such
Yeah.
patients.
Okay.
Another possibility would also be ankylosing spondylitis, which should be a possibility in this young because of though the back pain is not in keeping with ankylosing spondylitis, but expected that there's a murmur and also the chest findings. Though I would expect more of the chest findings in the upper apical part of the upper part of the chest. So these are my possible differentials.
Okay. Can I ask you what the cause of the sudden shortness of breathing and the Marfan syndrome?
Shortness of breathing could be due to sudden it
Yes.
could be due to sudden valvular it could sudden valvular affectation like the sudden valvular affectation in such patients.
Acute, you mean acute aortic regurg?
Yes, sudden aortic regurg, yes.
Another cause, doctora, especially in the Marfan.
I'm not sure right now.
Okay,
Yeah, you
doctora.
should know, please, Dr. Mayura. You will get it. Think about and you will get it.
Okay,
Short of
possibly,
Marfan.
possibly a Marfan syndrome, possibly a pneumothorax.
Yes, yes, yes. Pneumothorax, sudden pneumothorax. Okay, you can tell me some complication in the eye in the Marfan syndrome?
Okay, for the highs, we could see lens dislocation, usually to be an
Yes,
inferior lens dislocation.
yes.
Then
Upper,
uh
not inferior superior.
okay, in Marfan syndrome, lens dislocation. Then
Yeah.
that's
Okay. Okay, doctor. You know what the mode of the transmission of this disease, Dr. Ayula?
I think it's autosomal dominant.
Yes, yes, you are right. Okay, thank you. I finish my question, Dr. Ayula. You
Still
are good.
one, yeah, 1 minute. Let me ask here, what are the management steps in this patient, Dr. Ayula?
Management of multidisciplinary.
Excellent. And patient
For
with sudden
pneumothorax,
short of breath, what do you
Short, short,
think?
short of breath. Want to do an urgent chest X-ray imaging, and then if depending on how depending on the symptoms of this patient, if it's symptomatic, we want to give we want to do insert a chest drain, depending a chest drain.
No, it
Uh,
depends on the patient presentation. He came with acute short of breath with chest pain. What you should start with? What do you think?
Oxygen. What we want to assess the oxygen saturation.
So what we call these steps in acute presenting patient with such symptom. Patient,
ABC resuscitation.
yes, exactly. ABCD approach. Okay. Now the time of every step for the A,
Mm, okay.
airway.
Yeah. Wait.
Yeah. So here, what you should check.
Check if there's any obstruction. If
Okay.
the patient is breathing well.
Perfect. Yes. Then the B for.
Breathing.
So how you check?
For the breathing, you check for the okay, hey, airway obstruction. Then B, you check for the
Reflected and
breathing.
what?
Is that
Yeah.
what?
Reflecting on what? The breathing. Reflecting on what?
The oxygen saturation.
Perfect. So you check exercise. Okay, patient, for example, hypoxic, so you will,
Comment intranasal oxygen.
yeah, convince oxygen. Okay.
Oxygen, yeah, depending on the mode of delivery.
Okay, the C for.
For the cardiovascular, then you want to check the pulse and the blood pressure.
Do you think there is possibility here the circulation would be affected? Is it
Well,
possible?
yes, there's a possibility of affectation of circulation.
How? Tell me the reason. Possible reason.
Okay, it might be in a massive if it's massive
Perfect. What we call it.
pneumothorax,
tension.
tension pneumothorax,
Yeah. So what the management
compression
see?
of the. Is that what?
Yeah, exactly. So you should release this tension pneumothorax, right? So
Yeah.
if you start earlier with the multidisciplinary team and the patient is short of breath in front of you, you might miss the case and you might lose even your patient, right?
Yes.
So patient with short of breath, acute presentation, you should respect the complaint and start with ABCD. Even you can put him in the emergency or a high critical emergency area, right?
Mm.
Okay, so already stabilize the patient. Now your turn to manage the patient. How
In terms
about
of
pneumothorax? Yeah,
okay for the
in terms of pneumothorax.
after stabilizing the patient, then
Exactly.
depending on the symptoms,
Yeah,
if the patient is highly symptomatic, and depending on the background history that the patient have, if there's any any if it's a secondary pneumothorax, if it's primary or secondary pneumothorax, it will depend. The management will depend on this. So want to insert a chest drain if patient is symptomatic, and
perfect.
if it is a secondary pneumothorax.
So you will first check or assess is it primary or secondary,
Mm,
right? And accordingly you will manage. In
yes.
such reason or such case, what do you think the cause of pneumothorax? Is it secondary or primary, or spontaneous or
In
secondary?
this
What do you call
patient,
it? Yeah,
it is spontaneous.
perfect, exactly. So now you will go to the symptoms. If the patient is symptomatic, you might insert chest tube, particularly if it is tension pneumothorax.
Mm.
And some patients asymptomatic with the size, of course, you have to detect size in the X-ray. After the size detection, you can put him under conservative measurement and repeat the chest X-ray. So we'll not go about the steps or the approach of pneumothorax as intervention. How to manage this patient, particularly with Marfan syndrome? You
Okay,
suspect? Yeah.
it is a multidisciplinary approach, and
Yes,
then
perfect.
which will involve the cardiologist, the heart specialist,
Mm-hmm.
as well as the bone specialist and the genetics, the
Yeah,
specialist nurses, the social worker and occupational therapist
perfect.
for this patient. And we want to investigate for the cardio. Since this patient has a diastolic murmur, we want to investigate this murmur further by doing an echocardiogram for the patient to determine the severity, and also assess if there might be need for a replacement.
So
And
what is the possible cause here of this symptom? So the valvular heart disease in this scenario, what should be or what could be?
aortic regurgitation.
And the cause of aortic regurgitation in this patient is?
The cause of aortic regurgitation is the I didn't quite get the question.
Yeah, you have aortic regurgitation in this scenario or in this
Mhm.
patient. What could be the reason of the aortic regurgitation?
It's due to the collagen affection.
Okay, this is the pathology.
The
Yeah. So
Negative.
what you might find in the aorta itself? Is it aortic root or is it valvular origin?
valvular origin.
Are you sure? Marfan was valvular or aortic root dilatation?
I'm not sure really.
No, aortic root dilatation.
Mhm.
And it might affect the valve itself later on. Okay.
Mm.
So you already managed the cardiological point of view, the chest or pulmonology, thoracic surgery, already we talk about it.
Mm.
And the acute management of pneumothorax also we manage it. I think fair enough, 10 minutes already passed. Examiner. Yes, thank you, Dr. Ayala. Well done, by the way. Let's go to the Dr. Al-Huda comment, please, Dr. Huda.
Okay, you are good, Dr. Ayula, but you missed some question only about the case. Uh, the most problem came with the Morfan syndrome. They came with the shortness of breathing or
Mm.
chest pain, or they came with the visual disturbance or back pain. The cause of the chest pain, sometimes this is aortic dissection. Okay, and they have also sometimes spontaneous pneumothorax. The cause of the back pain in the Marfan syndrome, most dural and they have deformity, kyphoscoliosis and scoliosis. It's okay.
Mm.
Also, the eye problem in the patient with Marfan, they have cataract, glaucoma, retinal detachment, and lenses displacement. And this retinal detachment, the cause of the blindness in the Marfan syndrome. Okay. The cardiac problem in the Marfan syndrome, we have mitral valve prolapse, aortic regurg, and mitral regurg also, and aortic dissection. Because the dilatation of the aorta, the root of aorta, okay, Doctora?
Mm.
We must examine the span of the patient, okay? This they have high arched palate also when you examine the patient. I send the picture because this hand larger, there is one to compare, and you must examine the span of the patient. It's okay. Only they have aortic regurgitation. This patient, by examination, he has a pneumothorax, but you not examine the chest. Sorry, you not finish the examination of the chest. I told you there is degrees air entry. You
Wait,
must
wait, wait,
do
wait.
percussion because the patient has hyperresonance, focal resonance degrees, okay, and schistole because of a pneumothorax, okay.
Mm.
Uh, um,
Oui, oui, oui.
I told you also the blood pressure 130 over 50. That's
50.
meaning there is high blood. Sorry, not high blood pressure, pulse pressure, high pulse pressure. Uh, okay, only this I comment. You are okay, Doctor.
Yes, and thank you, Dr. Huda, for the case. Nice presentation of short of breath along with chest pain and, of course, cardiac manifestation. Dr. Ayula already approached the scenario well.
Yes.
She asked also about the constitutional here. It's important. But what do you think the farmer, if this patient is having chronic cough and he present with a cough not short of breath or even short of breath, along with his back pain, and he's farmer, apart from pneumothorax, what do you think the cause will be?
Intrinsic allergic.
Pulmonary
Fa-
fibrosis.
Farmer, he's farmer, present with the cough, short of breath, lymphadenopathy, fever, constitutional symptoms. Far-
Possibly a
Farmer.
brucellosis.
Yeah, what you said, Dr. Alvina?
Brucellosis.
Yeah, perfect. So put it in your mind. It might come in bases. It's not common, but yeah, whenever you have back pain and or you have farmer as occupation, think about brucellosis. It comes in bases, okay?
Mm.
But it will not be the same as there of severe chest pain or short of breath. It might be like constitutional symptoms, joint pain, yeah, fever, and lymphadenopathy, numbs or bumps, okay? Okay, back to the this case. I think the features of the patient is spot diagnosis. You can know the case from the first moment if you look at him. Okay, but if you don't look at him, it would be little difficult. But you have to put good differential for the acute short of breath, as Dr. Al-Huda mentioned, pneumothorax, particularly in the Marfan patient. Okay, but if you have another pathology or another patient different than Marfan, what are the possible differential you might have apart from Marfan as underlying cause? I'm talking about short of breath in paces, acute short of breath. Give me three reasons along with chest pain, Dr. Ayula. You have to be ready with good differential diagnosis.
So I have to think of pulmonary embolism.
Yes, this is the one I asked about. So pneumothorax, the top, chest pain and short of breath. Pulmonary embolism, short of chest pain and short of breath. What else?
Um, Myocardial infarction.
This is the third one, and also it comes in phases. So myocardial infarction with pulmonary edema, heart failure patient will be short of breath along with chest pain.
Mm.
The pneumothorax, chest pain along with the short of breath. The pulmonary embolism as well, short pain as well as short of breath, right? These are
Mm.
the most important. You can add to them pleurisy or pericarditis. Again, chest pain with short of breath. Sinusitis.
Aortic dissection also, Doctor.
Yeah, aortic dissection also, I agree. Yes, you have to roll aortic dissection. You will find it in the manifestation or in the description of the pain. Here the pain was dull aching, so it's something related to the lung. If it is heart, it would be the typical chest pain. What are the criteria of typical chest pain, Dr. Ayula?
Okay, chest pain. That is
Myocardial infarction, I mean.
yeah, myocardial infarction, chest pain, central chest pain,
Perfect. Central.
radiating
Compre-
to the jaw and the arm.
Perfect. And heaviness or tight
Heaviness.
compressing nature. Yes, exactly. What about pleurisy and pulmonary embolism? What's the nature of chest pain you will find?
Chest pain that is dull.
Yeah,
Sure.
and sharp, yes. And
With
increase what?
respiration.
Increase with what? Yes, Dr. Hoda?
Respiration. With
With breast
respiration.
respiration.
Yeah, with inspiration. So I think these are the clues for each short breath and chest pain cause. Pericarditis, absolutely right. If you said it is, if you have pericarditis, what the nature of the pain, and it's very specific type of pain in pericarditis.
Okay, in pericarditis, it's also could also be central
Okay,
and
and
worsen with inspiration and no, lying forward. Lying
perfect.
by lying forward, by
Yeah,
leaning
it's
forward. I mean,
Improve.
yeah,
Yeah.
improving with
Improve.
sitting forward
mm.
or yes. Okay, the last one is aortic dissection. What do you think the nature of chest pain in aortic dissection?
Sudden chest pain that goes to the back.
Okay,
Tearing. Tearing chest
and
pain.
severe and
Mm.
tearing chest pain, yes, and goes to the back. I think we've covered all questions for chest pain. You might have a typical chest pain just of myopathy or myositis, or even costochondritis. So remember the layers of the chest from outside inward or the opposite from inside outward. But you have to remember most of them, and you have to rule out the most serious one. In this scenario,
What's
it's pneumothorax. You will get it from the history taking, from the examination, but always remember to rule out the other serious causes of chest pain and short of breath. Okay. Okay. Back to the manifestation of this disease you missed. Yeah, I agree. You cannot get it in the systemic review because you cannot remember the question of hard or high arched palate, right? So you can find it after you see the patient. You see the patient, so you can look for the manifestation of Marfan syndrome. In this scenario, from the hand itself, what you should do, Dr. Ayula, in the hand?
and the what to do
Yes, tell me, what's called the sign?
I can't remember the name of the sign, but you ask the patient to wrap the thumb and the
Yeah,
middle
the
finger
thumb.
around
Yeah,
the wrist.
it's called thumb sign.
Thumb sign, yeah.
Yes, and what else? So he will make a fist and his thumb inside. You will
Mm.
find the thumb is
The two
almost
outside.
outside, almost yes.
Yeah.
And the other
Triangle.
sign is called
Then you ask him to wrap
Triangle.
his thumb and his hand around the wrist. It
yeah.
could go around it with it could I mean it could go around it
Which with which finger?
with the thumb and the little
And
Thumb.
finger.
exactly with the little finger. Okay. These are in the hand only. You have to do it. What else you have to do in the hand as vitals?
Radio femoral delay.
Okay, radiofemoral delay, but
Radial delay, sorry. Radial delay. Radio femoral delay.
no, no, it's not specific, but you have to check for the pulse volume.
Mm.
This scenario should be or could be high pulse volume. Why? Aortic regurg.
Position, yeah.
So even you might have the finding or the peripheral signs of aortic regurg,
Mm.
pulsatile nails, and as you said, the radiofemoral delay,
Mm.
the blood pressure sitting and standing, and the collapsibility, bounding pulse. It's very important.
Okay.
Yeah. Now the eye, if you want to examine the eye, but I don't think you can see the lens by the I think by the torch or there is special test. I cannot remember really.
Slit lump.
Slit lamp, yes, slit
Yeah.
lamp. Okay. The next will be the mouth. Open your mouth, please, widely, and you can just point with the torch or the light for the high arched palate. If you ask the patient to stand and examine his back, you might have some scoliosis or change or deformity in the back before examining the chest. Even though, as Dr. Al-Huda mentioned, the span, arm span, compared to the height of the patient, it would be higher or bigger than, right?
Mm.
The chest examination now, as a case presentation, patient present with short of breath, I will do from A to Z chest examination, inspection, percussion, inspection, palpation, percussion, auscultation. The limitation of expansion here would be present hyperresonance in the side of pneumothorax. Also, you might have a decrease of vocal resonance. And the last is auscultation, diminished airway as well. Air entry. Okay. The next examination, cardiac examination, because it's important to examine the complaint first. Now the cardiac examination apex beat first, localization, pulmonary hypertension signs and symptoms, and the murmur auscultation. Possibly here, aortic regage with a sitting position in the second aortic area more while sitting forward, right?
Mm.
Maybe there is mitral regage or mitral valve prolapse, but it's difficult to pick up this in the auscultation. Mitral regage will be having a pansystolic murmur, by the way, but the mitral prolapse, I guess it would be click,
Click.
right?
Yes. Mid.
Yeah,
Yes.
systolic click, yes.
Yes.
Yeah. Otherwise, in the tummy, I think on the abdomen examination, nothing important. Then the legs, also you can the height itself. I don't think we have another finding in the legs, right, Doctor
No.
Al Huda? Anything else? I
No.
don't
No.
think. Okay, this is the case. I think also as Marfan, everyone knows how the Marfan present in bases. It might come as cardiac station. It might come as here in this scenario, short of breath pneumothorax. You can also think about what other manifestation the Marfan might have. I
Back
would say
pain.
career. Back pain, okay. Yeah, as you said, ductal ectasia, yeah, one of the complications.
Visual.
So you have to
Visual.
examine the back as well, yeah. Vision issue, but it's not common to be presented with. So the most
Yes.
common presentation, aortic root dilatation and aortic regurg. Mitral, yes, could be there. He might have sternotomy with aortic valve replacement, also as a short case in the cardiac station. He might present it as in this scenario with pneumothorax. Okay, this is the case. I think we cover most of the point. Also, how to manage the pneumothorax. At the most important, firstly, you have to do the ABCD approach. This patient should be in critical area. It might be tension pneumothorax, and you might lose your patient while you are waiting for the chest X-ray or waiting for the pulmonology to come to assist the patient. You should do the ABC approach immediately. Chest X-ray urgent, pulse oximeter. If you suspect pneumothorax with decreased air entry, even you can do what's called, Dr. Ayula, particularly with hypotension. Patient with hypotension and he's severely hypoxic, decreased or diminished air entry in one side, hyperresonant,
Tension in pneumothorax.
tension pneumothorax. How you manage it in
The tube.
acute situation?
So, we
Sorry,
inserted the tube.
before
Just a
the
tube.
tube. No, before the tube. You don't.
Needle
You don't
decompression. Needle.
yeah, needed decompression. The tube will take time, and the patient might be not immuno, sorry, compromised, hemodynamically compromised, and he might even have cardiac arrest. So needle decompression first. You will put the needle in the second mid clavicular line, second intercostal space, and you will feel or you will hear gush of air. And after that, you might insert the chest tube, and the hemodynamics will be stabilized. Even you can do the chest X-ray, of course, first before putting the tube. Anyway, you should diagnose it with the chest X-ray, sometimes with the ultrasound. Okay. Any question for this scenario, Dr. Ayula or Dr. Al-Huda?
No, thank you.
Yeah, good topic, good presentation, good cases today. Thank you, Dr. Ayula, as well. Any question, Dr. Ayula?
No, thank you.
Thank you too. Let's open the discussion and I will read the comment if someone or anyone want to comment.
I put most of my comments in the comment chat, but just I want to say it. For the diagnosis, in the first, this patient
Yes.
come with acute chest pain. When you represent your case, you said like the diagnosis is pneumothorax in a patient with features of Marfan. So
Yes, exactly.
diagnosis is not Marfan. We are not searching about Marfan. We are searching about what this presentation with. And when you the investigation, I think we didn't we go through ABCD, but at the same time you need to mention the investigation, the bedside investigation, very important at this patient, as Dr. ask him say it will be first thing pulse oximetry, ABG, ECG. I will check for the pulses because the dangerous one here for patient with Marfan is dissection. So he may have aortic dissection. So this is very important to exclude and to investigate for. I need aortogram and for the investigation, chest X-ray the most first one ultrasound. We'll do bedside ultrasound because if it's tension pneumothorax, there is no time. So we insert the needle immediately. So you need to also still, this patient is still, he have Marfan syndrome and everything, but it's still, we can't exclude PE, as we say. So all the investigation of PE and if this patient may be reduced air entry, maybe he has pulmonary edema secondary to mitral valve prolapse. So still we need, the ultrasound is the bedside investigation at the moment. So we need to do a bedside ultrasound to see if this patient have pulmonary edema or he has pneumothorax. Or when I mean like it is acute case, I need to present it as acute case. What I will do at that moment. So it is not about the Marfan syndrome at the moment. It's about what this patient have now, pneumothorax and these things. I mean, just in the presentation, you need to reflect that you are reflecting a severe case. You understand what I mean? So you need to present what this patient now having.
Yes, absolutely right. So you have to mention why he's short of breath, not why he's what's his possible diagnosis as a underlying cause. Yes, you have to mention it. However, the short of breath should be explained earlier and firstly in the presentation. This patient with these features might be features suggestive of pneumothorax in the light of Marfan syndrome, for example. Okay, this is the way how to present. So don't say it's Marfan. Yes, of course he's Marfan, but why he's short of breath? Not every Marfan will be having short of breath. Okay, so you have to give him the possible differential as well as for the patient himself while explaining the condition. You have to tell him what he has, why this patient is short of breath. I should run some investigation, of course. If you are lost and you don't know the case, at least try to mention to him that we some the possible cause in my mind right now. I'm not sure about them. I should run some investigation and try to collect your thoughts before going to the examiner. During this time, you have to know why this patient is short of breath. Okay, but if you missed in the patient's concern, at least remember in the examiner questions. Thank you, Dr. Mayada. Again, diagnosis is not Marfan. Yes, must be something related to the symptoms. Complaint of pneumothorax, most probably yes, sudden short of breath. Differential aortic dissection, pneumothorax, mitral prolapse or mitral regurg as a complication to mitral prolapse. So mitral prolapse is not acute presentation. The mitral regurg is might be the acute presentation of the mitral prolapse. Okay, mitral prolapse can happen, but it's not something emergency. The regurg is the one. Present your case, yes, upper, not the positive finding, please. Yes, management first investigation, bedside, pulse oximetry, exactly, ABG. Any patient with chest symptoms, you want to do something bedside, you have to mention ABG and pulse oximetry. Chest X-ray later on, or I mean after that. But every patient with chest symptom, the first thing to do to connect him to the monitor and read his oxygen saturation. ABG, then chest X-ray. ECG, of course, you have to consider blood including D-dimer, BMB, urgent chest X-ray, aortic angiogram if you suspect aortic dissection or aortic regurg. Multidisciplinary team agree. High archipelago you have to check. The ACS, acute coronary syndrome, pulmonary embolism, aortic dissection, pneumonia. Okay, pneumonia will not be as acute. Who's that? Dr. Maida. Yeah, so pneumonia, yes, could be one of the differential, but it could be with the long term or chronic course, not as acute. The pulmonary edema, yes, I agree. Patient will be presenting in acute within hours or minutes. But the pneumonia will be, for example, for 2 or 4 days subacute, maybe 10 days not responding to medication, and so on. Diagnosis, we will be pneumothorax in patient, the future of Marfan, need to exclude aortic dissection. Agree. Well done, Dr. Ayula. Yes, I agree. Very well done today. 2 cases, very nice case. Thank you, Dr. Nahla as well. Dr. Marwa, diagnose include aortic issue, acute issue, underlying condition associated if any of any all are important. Yes, exactly. If there is even vision problem, you have to mention. And Dr. Ayula, you have to ask about driving with any patient with vision loss or vision affection. Any question, Dr. Ayula, Dr. Al-Huda?
No, thank you.
No,
Yeah, being 2 hours now, but it's good session really. Two cases, new cases. We I think we didn't discuss commonly these scenarios, but already discussed today. Anyone with question before ending the session? Thank you, Dr. Mayada, as well for the comment. Everyone also commented. Thank you, everyone. We can end the session if no comment. I think so.
Thank you.
Thank you again, Dr. See you tomorrow, inshallah, with the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.